Of note is the fact that the Healthcare Consent Act does not dictate how regularly and over what periods of time capacity should be reassessed. That's something that's under clinical purview, and a clinician should turn their mind to that at reasonable intervals in order to ensure that they're allowing a person who is capable to make their own decisions if they've been previously incapable. Another thing just to remember is that the person who assesses capacity is the health practitioner proposing the treatment. So if treatment is to be started, even in an emergency room setting, and it's for a mental health issue, if it's the emergency room physician proposing the treatment, that's the person that determines capacity. If the psychiatrist is proposing treatment, the psychiatrist assesses capacity. And it's quite clear in the Act that that's how capacity should be dealt with. The test for capacity essentially is a two-pronged test, and in order to determine that somebody is capable to consent to their own treatment, they need to be able to understand the information that's relevant to making a decision about treatment, and they need to be able to appreciate the reasonably foreseeable consequences of a decision or lack of a decision. So the understanding part of that test, which many people pass, is that they can hear what you're saying globally about a condition and what kinds of treatment might be appropriate to deal with that condition. The issue of appreciate is often the place where people fail on the capacity test because appreciation requires some insight and an ability for a person to take information given about treatment and apply it to their own situation. And many people who have significant mental illnesses and lack insight into that fail to be able to consent to treatment because they are unable to pass the appreciate part of the capacity to consent to treatment test. Should a finding of incapacity be made, regardless of where it's made, whether it's in the emergency room, in the community, in a different hospital-based setting, the person must be notified that they've been made incapable. They are required by law to receive rights advice. They can appeal the finding that the physician makes or the healthcare practitioner makes around the finding and request to go to a review board to have the decision evaluated. If somebody is incapable, a substitute decision maker must be appointed, and the substitute decision maker must base any decisions they make around treatment on prior capable wishes of the person or use a best interest test. So finding somebody incapable to consent to treatment is quite there's quite a challenging series of actions that take place when that finding occurs. But I think it is important to remember if somebody is able to make their own decisions or does not meet the test for emergency treatment, even in the emergency room, the Healthcare Consent Act does state that a discussion around informed consent needs to take place. You can presume capacity unless something comes up in that decision that makes you concerned about the person's capability. And as soon as you're concerned about capability, then a capacity assessment is warranted in that you will determine if that person can understand and appreciate treatment that's been proposed. And if that person cannot, as you can see on this last slide, there's a number of other actions that are required to take place as spelled out in the Healthcare Consent Act. This slide basically is a flow diagram that summarizes this and is probably quite handy to have on board if there are concerns around incapacity and how to deal with that. So just going back to our case study then. So our lady is on a Form 1 and in terms of the last step, after she threw the jug of water, it was felt that she was escalating subsequent to that, and PRN was given to her to help her settle in terms of some emergency intervention. And what has currently happened now is that we're at 4 hours later, and the Schedule 1 facility that you're waiting to hear from has just phoned in saying that they continue to work over capacity and they feel it would be a patient safety issue to accept the patient currently in transfer. So the police who have been with the patient on a Form 1 for this period of time are now getting frustrated, as they've been there for 7 hours waiting to find out if the person's getting transferred and what's happening next. Because you gave her some PRN medication, she's now fallen asleep and appears to be quite a bit more settled, and the police inform you that they would like to go. How should you respond at this point? Well, again, the Mental Health Act speaks to this specific issue, and under Section 33 outlines the rules around transfer of custody of the person. And essentially what it says is that a police officer or other person who takes a person in custody to a psychiatric facility shall remain at the facility and retain custody of the person until the facility takes custody of him or her in the prescribed manner. And what that basically means is that until the receiving facility, and in the Act it says the psychiatric facility, till that facility formally accepts custody of that person, whoever has brought the patient in originally shall continue to keep that person in custody until that final transfer. So, back to our case study and what's happening next. So the police just agree to stay with the person pending transfer to the Schedule 1 facility. And at the 8-hour mark, the patient wakes up. And after waking up, she's had a PRN, her intoxication is more settled, and she is able to communicate much more reasonably with you. And what she says is that she's sorry, she was really drunk, and she just wants to go home. You note that she makes poor eye contact and she looks quite embarrassed about what happened. And she says that she has no intention of jumping off the balcony. And she says that she'd just like to go home, and she agrees that she'll make an appointment to see her psychotherapist in the community next week. You check back in with the Schedule 1 hospital, and they now let you know it's going to be at least another 4 hours before she can be transferred on her Form 1 for her assessment. Can you discharge her from the emergency room? First thing we need to do is just review what the Mental Health Act says in terms of somebody being put on a Form 1 and what the disposition of the patient is once they've been put on a Form 1. And Section 20 speaks to the duty of the attending physician. And the attending physician that I think they're referring to in that section, although it's not 100% pointed out, is the attending physician at the Schedule 1 facility who is doing the assessment on the Form 1. So what Section 20 says is that the attending physician, after observing and examining a person, can either release the person from the psychiatric facility if they are of the opinion that the person does not need treatment in a psychiatric facility, or they can admit the person as an informal or voluntary patient if they feel that the person is suffering from a mental disorder requiring treatment and that they are suitable for admission as a voluntary patient. And the third option is that they can admit the person as an involuntary patient by completing Form 3, which is a certificate of involuntary admission, if all the conditions for that are met. So the Mental Health Act really says there are 3 things that can happen once a person has been put on a Form 1. The whole issue, though, and this is something that certainly happens in clinical practice, is can a person be discontinued from a Form 1 prior to transfer for psychiatric assessment? The Mental Health Act gives no direction about this, and there doesn't seem to be any case law that speaks specifically to this issue and clarifies for clinicians from a legal perspective whether or not this is something that we can do. We know that it's done regularly at the Schedule 1 facility where I take call if somebody has not been referred back to psychiatric emergency for assessment. The emergency room physician will discontinue the Form 1 if they feel the person no longer meets that Form 1 criteria, and certainly it can happen in some other places. what do we need to do in terms of if a decision is made by a clinician, and in this case that I've just presented, what would happen in this particular situation? Well, I think the first thing that you would have to do if a patient had presented in that way and then looked much more settled is that you'd really want to ensure that you'd taken a good history. If you remember back to the beginning of this presentation, what I'd said in the talk was that this is a young lady who presented with clear intoxication. She was out of control. She was threatening to hurt herself. What's of note in her history is that she in fact does have a diagnosis of major depressive disorder with a significant suicide attempt several years ago requiring a 1-month hospitalization. And it would need to be very clear in any documentation prior to releasing this lady, if she wasn't going to be transferred to the Schedule I facility, that a good history had been taken where potential risk factors for suicide, including her prior suicide attempt and history of mood disorder, had been taken into consideration, had been clearly assessed, and had been dealt with in terms of her disposition prior to releasing her from her Form 1. Other things that are probably really important to document in these situations would be to obtain good collateral information. So again, in this particular case, we were unable to get a hold of the boyfriend or family, but attempts should be made to do that again to get collateral information, looking for evidence of recent symptoms and signs of mood disorder, which might have been covered up by her presentation through intoxication. If you're unable to transfer the person to the Schedule I facility imminently, there may be the possibility of at the very least doing a phone consultation with a psychiatrist on call and having their input as to whether or not this person could be released prior to the Form 1 assessment at the Schedule I facility, just to support and review the information that's been taken in the clinical decision made. And there should be a clear discharge plan in place with identified follow-up and good documentation that supported this. So again, just with this point, the Mental Health Act then suggests that on a Form 1, the person would go to a Schedule I facility, and there's 3 options for disposition following assessment at the Schedule I facility on the Form 1. In practice, if that is not reasonably, if that's not practicable, and it looks like it's going to take a day or 2 days to meet that forthwith criteria on the Mental Health Act, if consideration is being taken to nullifying the Form 1 and discharging the person prior to psychiatric assessment, then it would be really important to go through the steps that I've just outlined around good history taking, assessment of risk factors, collateral information, and a discharge plan in place.